Hi, we're talking about ischemic heart disease, epidemiology, risk factors, diagnosis, and treatment. This is a problem that affects up to a third of all Americans. Up to a third of all Americans will die from it, rather. And about half of all American men and around a third of all American women will be affected by ischemic heart disease or coronary artery disease. One of the most important reasons to talk about this is because it is a disease that is modifiable by lifestyle and also by medical treatment. So if we are able to manage the disease, we can greatly decrease morbidity and mortality. So not to poke fun at the American smoking his cigarette, eating French fries, and drinking alcohol. But this is a lot of the risk factors are shown in this picture here. Diabetes is probably the most important risk factor. And as we know, it's not completely preventable, but in some cases it can be. And it is certainly treatable, though studies do not show necessarily that tight glucose control will reduce risk of coronary artery disease, but it certainly won't hurt it, so it's not a bad idea. So smoking is a big risk factor. Hypertension, which we're pretty good at treating. Hypercholesterolemia, which we also have some good drugs and some good methods to treat. Family history, obviously we can't choose that, nor our age or our gender, though many people do try. So the major variations of coronary artery disease include stable angina, which is caused by atherosclerosis, narrowing of the arteries, and causing insufficient blood supply. So this is when you are at rest. Usually you're not going to have any problems with this, but once the heart is exercised, then it's not going to have enough blood to keep up with the higher output. Unstable angina and end-stemming, people consider this to be kind of on a spectrum. It's caused by transient clotting of atherosclerotic vessels. In unstable angina without end-stemming, we have a transient clot that goes away before any damage to the heart muscle is sustained. Prinzmetal's, sorry I spelled this wrong, Prinzmetal's angina is a fairly rare condition caused by coronary artery vasospasm. It's probably not going to be something that you see all the time. And then, of course, you have a ST elevation MI, which is usually the more serious, and it causes death of heart muscle. So in diagnosis, history is very important here. If you have angina on exertion, relieved with rest and nitroglycerin, then we're probably talking about stable angina. If you're having angina at rest, then it's probably a more unstable condition, or it could be an end-stemming and possibly Prinzmetal. If it's not relieved by rest and it's accompanied by diaphoresis, nausea and vomiting, and dyspnea, then usually we're thinking of a ST elevation MI. So on EKG, if we do have a STEMI, then we'll see ST elevation. Prinzmetal angina can also cause ST elevation, but it's usually transient and it's not associated with a Q wave. So that's something that you can recheck. Also, we're not going to be seeing any elevation of cardiac enzymes, which we'll talk about in a second. So Q waves are associated with STEMIs. ST depression and T-wave inversion are usually associated with NSTEMIs or stable or unstable angina. So an angiography is kind of the gold standard for confirming the diagnosis of coronary artery disease. And you want to get the cardiac enzymes like CKMB and troponin to rule out MI. Now, CKMB and troponins are fairly similar in their diagnostic value, but troponins last a little longer, up to a week. So, whereas a CKMB, you only have about 48 hours to detect it. So, how do we treat angina? Well, if we have acute angina, sublingual nitroglycerin can help relieve the angina. And you can take up to 3 doses at 3 to 5 minute intervals. If that's not working, then you might want to move to some of the other methods that we have listed below. So long-acting nitrates. You can also do nitro drip, beta blockers, aspirin, smoking cessation. If you treat with statins, and folate is a question mark because we're not totally sure how effective it could be in chronic prevention of angina. Angioplasty is an important method. It is historically associated with less risk than coronary artery bypass graft. But the CABGs are getting pretty good, and so they're not associated with as much risk as they used to be. So, treatment of unstable angina. We have this table here that's adapted from boards and wards. But basically, if you have a low risk, meaning that you're probably not going to have any recurrent unstable angina or an MI, then this is resting pain less than 20 minutes, usually relieved with nitroglycerin. You can give aspirin, O2, beta blockers, and sublingual nitroglycerin. So if you add longer pain, it's you can nocturnal angina, T-wave inversion, ST depression. Then we're starting to call it intermediate risk, and you can add a longer acting nitroglycerin. You might consider using heparin. And then if the ST depression is more pronounced, and if we have positive troponins or acute pulmonary edema, then we might want to add a nitro drip or a GP2B, GP3A antagonist. And you're definitely going to want to do heparin. So if we do have a confirmed STEMI, if we get it within the first 6 hours, then we'll want to do thrombolytics like TPA or streptokinase. If we're given TPA, we want to give heparin as well. Angioplasty is also a preferred method of treating ST elevation MI. A coronary artery bypass graft isn't going to really help us in the acute setting, but it may be a good long-term treatment to help us to prevent future MIs. And then you want to give them aspirin, definitely, and a beta blocker, definitely. Statins, or they say to control lipid levels is an important treatment. Statins may have a separate effect on inflammatory processes, and that may be one of the reasons that they help to decrease mortality in these patients, but those studies are still ongoing. Oxygen and morphine, especially for pain. ACE inhibitors help prevent remodeling, which is good for heart muscle. And then, of course, these guys need to stop smoking. They should probably do some exercise. So, as you send them out the door, make sure they're stopping smoking. If they get a stent, they need to be on clopidogrel for a year. Aspirin, nitroglycerin, beta blocker, statins we talked about. So the purpose of this is not to guide clinicians. Not that I think any clinicians would be using this as a guide, but of course you have Up to Date as a resource. And if you do have comments for me, please send them to kendrick@themedschool.com. We'd like to make these presentations better so they can be a good resource for medical students or anybody else who wants to learn about medicine. So please direct your comments to kendrick@themedschool.com or leave them on YouTube, and help us know if there's important things that we left out or inaccurate information. Thank you.